So, thank you, Werner, for the invitation. And you see, when you look at the title, I've changed it a little bit because I said differentiating not toxic from immune-mediated, but metabolic from immune-mediated reactions, because the immunological reactions are also toxic. And yes, so I think this is a better title. So, okay, this is the the classification, my classification of liver toxicity, drug-induced liver toxicity. Of course, this is the classification of a non-immunologist, and I would say there is metabolic or non-immune mediated toxicity, the subject that I should talk on. And you see, I have to look, yes. I say there is drug overdose. These are the formerly called intrinsic reactions or type A reactions. We think that we understand them, and you see some examples, paracetamol, I'm going to talk about, etc. And then we have reactions that are happening at the therapeutic dose. This is different. We had overdose, we have therapeutic dose, and of course the immune-mediated toxicity is also normally at therapeutic dose. And you see the mechanisms are often not known here, and the patients that are affected, they have to have susceptibility factors. Otherwise they would not have this toxicity. And they can occur at any time during treatment, depending on the susceptibility factor. The susceptibility factor may change. It may, you see, think on a drug induction. A new drug, induce a SIP, and then the patient may have an adverse reaction, which may affect the liver. The histology is depending on the mechanism, so we should know the mechanisms. I said usually we don't know them, but we have learned a lot in the last time about the mechanisms. And you see the examples, again, paracetamol, I have to explain that afterwards. Isoniazid for me. I know that Werner would say this is immunological. I say this is probably not immunological. And we have valproic acid. You see, I have valproic acid also here, because valproic acid is a very complicated toxicant to the liver. I'm going to explain that later. And then we have the immune-mediated toxicity. I do not want to go into that. You have heard already a lot of it. So, of course, when I go back, Silvan, what I would say, we should not talk about intrinsic and idiosyncratic toxicity anymore, because we have immune-mediated and non-immune-mediated, and dependent on the dosage or occurring at therapeutic dose. I think this is a better, it gives us a better understanding of the reactions. So now here you see the principal mechanisms that we think how it could happen. Here on the base, the immune-mediated reactions that you heard already. You see here the hapten mechanism, which is proposed by these authors. Werner would say this does not exist, okay. And then we have I think this is the PI concept. You see the drug which interacts either with the T-cell receptor or with the MHC1 in that case, because it's a hepatocyte. And then you have the things that I would like to talk about. You see, the drug comes from the blood, crosses the space of T-cell, is transported into hepatocytes by several transporters, may be metabolized in the hepatocyte, and then the parent drug or the metabolites may affect the mitochondria. It may affect the ER, causing ER stress and then apoptosis, or it can also interact with transporters, which the one which is a very characterized interaction is with the BSEP. This is the bile acid transporting protein, When this is inhibited by a drug, then the bile acids would increase in the hepatocyte, and this may be toxic. So I start with paracetamol. Paracetamol, I told you, is quite complicated because it is dose dependent. That means at overdose, but it is also toxic at therapeutic doses in certain patients. Here you see the overdose. This patient, when you look at the paracetamol concentration here, this is day 1, is 120 milligrams per liter. So this patient ingested about 12 grams of paracetamol. And you see what happens. Day 1, the bilirubin is already a little bit increased here. It's over 2 milligrams per 100 milliliter, and the coagulation is already impaired, but the transaminases are still normal. So the cell is damaged already, but it is not, we have no cell lysis. The cell lysis comes at day 2. You see that here, tuck, it goes up. And about, I would say in this case, about 50% of the hepatocytes are destroyed. And then the patient recovers, you see, everything goes back. And you see also that the kidney is affected. The effect in the kidney is a little bit later. Probably it's the same mechanism. I think we don't know exactly, but it's probably the same mechanism. The creatinine in the serum goes up, and then it normalizes. Okay, this patient survived. The explanation is, of course, the metabolism of paracetamol that you may know. You see paracetamol, this nice molecule, and usually it is glucuronidated or sulfated, and you see the capacity is large, and when you don't have an overdose, normally you have no problem. And when you have an overdose, you may produce this electrophile metabolite, NAPKI, which is produced by certain cytochromes, mainly cytochrome 2E1. This metabolite is toxic. It can be degraded, or it can be conjugated with glutathione, which gives electrons to the metabolite. And usually then it is excreted by the bile, nothing happens. And when the glutathione is depleted in the hepatocyte, then it reacts with other proteins, usually with enzymes also from the respiratory chain. And this is probably explaining the toxicity. Okay. And this is the result of it. You see what happens in the liver. This is a necrotic zone. And when you look here, then you see that there's a central vein. So it's a central acinar necrosis that happens. And why is it central? Because the CYPs are expressed in the center of the liver lobule. And you see that the periphery is still intact. This patient has probably a little bit of too much fat in the hepatocytes. Maybe it's an alcoholic, and alcohol induces CYP2E1. So this patient had also a risk factor beside of probably ingesting too much paracetamol. And just to make a bridge to the immunologists, you see this, when the patient survives, this necrosis has to be taken away. And this is by inducing the inflammasome, which is expressed in hepatocytes, but also, of course, in macrophages, Kupffer cells, and other cells. And when we have production of IL-1 beta, then we have activation of the innate immune system with macrophages, which can then take away the damaged cells. But you have something else also with paracetamol. Paracetamol can also be toxic at therapeutic doses. So we have one thing is overdose. This is one risk factor, it's clear. But patients, for instance, alcoholics, like here, when they have an induction of the CYP2E1, this enzyme, which makes the toxic metabolite, they can develop toxicity. And you see that here, these are patients with liver toxicity ingesting less than 6 grams of paracetamol a day, which is usually not toxic, but they drank alcohol between 30 and 80 grams per day. This means 3 to 8 servings, glasses of wine a day. And you see they had high transaminases, a high mortality. And so this is drinking alcohol is a risk factor that you develop the other type of hepatotoxicity. And we have that also in patients that are not ingesting too much alcohol. You see, this is a study that was done in normal subjects, 26. They were treated with 4 grams only. This is what we say. We usually tolerate it. And these were subjects not ingesting too much alcohol. And there is, at the moment, no explanation why 10 subjects, this is about a third of the subjects, developed transaminases more than 3 times upper the limit of normal. And nobody of them had an increased bilirubin concentration. They were asymptomatic, but we have toxicity also clearly at a normal therapeutic dose. When we summarize that, so susceptibility factors for liver injury at therapeutic paracetamol doses, alcohol, as I told you. When you stop drinking, it takes about 1 to 2 weeks that this is normalized again. This is the half-life of CYP2E1. And other CYP inducers, isoniazid, important, and phenytoin, other CYP inducers, because this toxic metabolite can also be produced by CYP3A4 or 2A1. And pharmacogenetics, this has not been shown. So this is speculative, not so much as you are, but a little bit. But there are pharmacogenetic variants which increase the activity of CYP2E1, and this may be the cause why, even when you don't drink too much alcohol, you can develop a toxicity of paracetamol at therapeutic doses. Okay, now let's change to valproate. Valproate is this molecule here, a very small molecule. It's C8 fatty acid that we use to treat patients with epilepsy. And you see, it is hepatotoxic. We know that about 40% of the patients, when you start the treatment, they develop transaminases. Normally, we can go on, we know that very well, and the liver somehow adapts to this drug, and transaminases normalize, and we go on with the treatment. And what is not so really good known is about 60% develop steatosis, too much fat in the hepatocytes. We studied that, and we think it's the excretion of VLDL, which is inhibited by valproate. And depending on the dose, clearly, some patients develop hyperammonemia. I come to that, I give you the explanation. This is at therapeutic dose, and or also when we have very high doses. And at therapeutic dose is the fulminant liver failure. And you see here just a small part of the metabolism of valproic acid. Usually valproic acid is metabolized by glucuronidation here at the carboxyl group. And a very small part is metabolized here in the side chain by CYP2C9, a cytochrome. And it can be a hydroxylation, it can be a dehydrogenation. You see these hydroxylations. And an intermediate is formed, which is a radical, which is always a little bit difficult for the liver, just to tell you. Okay, first, hyperammonemia. We understand that quite well. You may remember the urea cycle, 5 enzymes. The first one is carbonyl phosphate synthetase, which is the rate-limiting enzyme, ATP-dependent production of carbonyl phosphate from bicarbonate and from ammonia. And this enzyme is regulated by N-acetylglutamate, so glutamate, which is N-acetylated, and which activates the enzyme. And the enzyme which is forming N-acetylglutamate is NACS, N-acetylglutamate synthetase. I know that very well. My first PhD thesis was the isolation of this enzyme from human liver. Okay. And you see, the problem is that when there are other, so the substrate for acetylation is of course acetyl-CoA, and when there are other substrates as acetyl-CoA, like propanyl-CoA, you see that here, then this reaction is inhibited. And when valproate is degraded, it can also be degraded by beta oxidation, and then propanyl-CoA is formed, and it is formed enough that this enzyme can be inhibited. And when we increase the dose, it can inhibit the activity of the urea cycle, and then the patient can form hyperammonemia. The other type of toxicity is the liver failure. And the liver failure clearly is not dose dependent. It just happens at therapeutic dose. You see that it is more often seen with polytherapy. It is more seldom with monotherapy. It is more frequent in children than in adults. And the onset is usually in the first 3 months. And the clinical picture is the fulminant liver failure, and the histological picture is microvesicular steatosis. This is here. Microvesicular steatosis usually means that it's an inhibition of the beta oxidation, and beta oxidation is happening in the mitochondria. And I give you just one patient that we described. You see, the publication is almost as old as your publications, Werner. And you see, this is 30 years old. Okay, and this is just reflecting our age. Okay, and this was a patient with bilateral ptosis. You see that, and this may be mitochondrial disease. It doesn't have to, but it may be. And she developed a status epilepticus at the age of 39 years and was started on valproate. And then this was not sufficient. She still had seizures, and the valproate was combined with carbamazepine. Carbamazepine induces CYP2C9. And then she developed liver failure some days after, 1 or 2 weeks after, and she died. She could not be transplanted. She died at the age of 39 years, and the liver had this microvesicular steatosis. It was clear it was valproate associated. Now, this patient had a sister, and the sister died of respiratory failure at the age of 37 years. And from this patient, I received muscle biopsy, and I studied the activity of the electron transport chain, and you see she had a reduced activity of complexes of the electron transport chain. She had a mitochondrial disease, and now I could combine. Probably this was a familiar problem, and probably the other patient with the liver failure also had a mitochondrial disease, and we said in the year 2000, mitochondrial diseases are a risk factor for this valproate-associated hepatotoxicity, for the severe hepatotoxicity. And this was then confirmed 10 years later by an American group, and they said that so-called POLG mutations are a risk factor for this severe toxicity. POLG is the polymerase gamma. Polymerase gamma is a nuclear enzyme. It's encoded in the nuclei. It then goes into the mitochondria, and it's the DNA polymerase for producing the mitochondrial DNA. And we know patients with this syndrome, the Alpers-Huttenlocher syndrome, they have a decreased activity of POLG. And you see what the consequences. they just they have the mitochondrial disease. This is a multi-system disease because they have difficulties to produce the mitochondrial DNA, and 13 proteins within the mitochondria are encoded by this mitochondrial DNA. And you see here now, these authors, they published 17 patients with valproic acid-associated hepatotoxicity, severe hepatotoxicity, and in 8 of these 17 patients, they found a POLQ mutation. And you see the POLQ mutation in the normal population is 1 to 100,000. So it's a clear overrepresentation, and you see that this is a risk factor for the hepatotoxicity of valproic acid. This has been confirmed now several times. So we see we have 2 things probably what happen. These patients are they have a damage of the mitochondria. They are not recognized. They may even have the fits when they are children, the seizures because of this damage. They are treated with valproic acid, and valproic acid damages the mitochondria because of the production of these metabolites, which are mitochondrial toxicants that I showed you already. So this is one risk factor. And then they may be treated with CYP inducers, which increase the production of these metabolites. So this is typical. So we have the toxicity, we have a mechanism, and we have the susceptibility factors. And this is what we want to have. The last example is bosentan. Bosentan, you may remember, bosentan is an endothelin receptor antagonist. It's used to treat patients with pulmonary hypertension. And bosentan is transported into hepatocytes by these carriers. These are anion carriers. And then it is metabolized mainly by CYP3A4, but also by CYP2C9. And it is thought that bosentan can inhibit BSEP. And when BSEP is inhibited, I told you, the bile acids are going to increase in the hepatocytes, and this may be toxic. So this is the idea. I give you one example of such a toxicity. This patient was treated with a normal dose of bosentan, twice 125 milligrams per day. And then after about 1.5 years, suddenly, we don't know why, the patient had an increase in bilirubin and the transaminases, so severe hepatotoxicity, and bosentan was stopped. It was suspected that this could be bosentan, and the patient also received a treatment with prednisone, which may have been beneficial or not. And maybe it's only stopping bosentan, which then cured the patient, and you see everything went back, and the patient was not re-exposed to bosentan. We know that bosentan makes transaminases in about 3 to 18% or 10% of the patients, and we know that the bosentan has to be stopped in about 4% of the patients. Usually this happens 1 to 6 months after beginning of treatment. In this patient it was later, and the enzyme pattern is typically hepatocellular or mixed, and immunoallergic features are not present. We don't find them in these patients. That's why we make monitoring, and we discontinue the treatment in certain situations. So the possible mechanism I already mentioned. You see here, this is from a publication of Karin Fattinger from Zurich, from the group of Peter Meyer, who actually cloned the BSEP here. And you see that patients that are exposed to bosentan dose-dependently have higher bile acid concentration. So this is in favor of the hypothesis that this toxicity may have something to do with the bile acid concentration. And you see here how bosentan inhibits the the transport of bile acids by BSEP. Here BSEP in insect cells, and here BSEP in the normal environment in vesicles isolated from the canaliculus of hepatocytes. And you see bosentan and especially also the metabolite M2 still stronger inhibit this transport. When I go back to M2, M2 is here. And M2 is formed by CYP3A4. And CYP3A4 induction may therefore be a susceptibility factor. You see, the hepatotoxicity was then studied further, and pharmacogenetics was done. When you look where would you do pharmacogenetics, you would look at the OATPs. You can look at CYP2C9. With CYP3A4, we don't have pharmacogenetics and BSEP. And to make a long story short, nothing was found. There is no pharmacokinetic clue or risk factor that would predict the toxicity. And in my view, as I told you already, it could also be the induction of CYP3A4. So I don't know whether this patient had received some inducer. Now, the second last slide is the differentiation between metabolic and immune-mediated toxicity. You see the clinical type, I would say, in my experience, the metabolic toxicity is more often hepatocellular. That means transaminases. Hepatocytes are destroyed, and the immune-mediated may be more often cholestatic or mixed, so that the target may be the hepatocyte, but also the bile ducts. And the clinical features, you have heard already much about the DRESS, and this may be associated with immunological immune-mediated. Then the histology. You have seen histologies from also from Werner. Eosinophils and mononuclear infiltrates are often seen, and we don't see that so much with metabolic toxicity. Here, the histology depends clearly on the mechanism. When you see these fat droplets, etc., then we know probably it's mitochondrial. And then susceptibility factors. This is the HLA constellation here. Maybe there are also other constellations. And here, as I've told you, this may be CYP induction, enzyme polymorphisms, mitochondrial dysfunction, anything. Clinical course. This is usually rapidly reversible, the metabolic, when we know the drug and we stop it. And immune-mediated may take longer, in my experience. And usually we treat then, when it's severe, with prednisone. The treatment here, I've mentioned already, there are no control studies. Actually, the idea with other immunosuppressants may be interesting. And here, of course, in both cases, stopping of the culprit drug is essential. So, to conclude, the differentiation between idiosyncratic and intrinsic toxicity, I would say this is old. We should not do that anymore, and we should develop a better system. Maybe mine, maybe another one. Metabolic toxicities are heterogeneous, and so it's more complicated. Actually, it's even more complicated than immunology, I would say. And regarding the clinical presentation and mechanisms, and usually respond rapidly upon stopping of the culprit drug. This is less complicated. And the differentiation between metabolic and immune-mediated is possible. I think is quite well possible also from the clinical spectrum and from the histology and other factors. Thank you for your attention.
Thank you, Stephan. So we see now that metabolism can be as complicated as the immune system. I'm convinced. So, questions, Werner? Yeah.
Thank you very much. As a case, a metabolic DILI, cause metabolic DILI, associated with eosinophilia. Do you have that? Or if you have eosinophilia,
usually
it's
there are
not.
some eosinophiles in the
Okay,
histology.
so if you have eosinophilia, you have drug-induced immune reaction. With exanthema, what about exanthema?
Then I would say this is probably immunological.
Okay,
I would
also
say.
immunologic.
Yeah,
So
yeah.
you can exclude when you have eosinophilia, exanthema, it is not metabolic.
No,
No?
I would say no, because I think there is an overlap. You see, when you have metabolic toxicity, you have so much things that happen, so much danger molecules that are expelled, and I think you have, in most cases, probably have also involvement of the immune system, that you can have activation of the immune system. That's why I brought the paracetamol case.
Okay. And why did this patient with Bosantan develop the DILI after 18 months?
Maybe, you see, that's why I said maybe induction of CYP3A4 is a possibility. And this is when you take Hypericum or something like that, a tea or something like that, you can induce it. It's no problem. Yes. It's no problem. Yeah. This is what people do, and they don't tell the doctors. That's the problem. Yeah. So from the drugs the patient was treated, I did not see something that is inducing this patient, but this is always possible.
What is more common? Which one is more common?
I would say metabolic. I thought about this question. I thought that you would ask that, and I already knew my answer.
I'd have a question as to cefuroxime in a patient who had DILI to amoxicillin. The question would be, would you dare to give cefuroxime to a patient who had DILI to amoxicillin?
I'm now not sure. Not sure anymore. Maybe I would first I would first send the blood to Daniel. Yes. Yes. No. Probably it's immunological, and so we know. We published actually about beta-lactam-associated hepatotoxicity, and probably it is immunological, and probably nothing would happen. Yeah, they are too different chemically, but if you want to be precautious, it might be a good idea to ask Daniel.
A last question maybe. So concerning paracetamol, so the metabolism induce quite a lot of time some reactive intermediates that could quite easily form haptens. But in clinically, actually, paracetamol at the level of allergy is very safe. And also 8 grams it's a huge dose compared to other drugs currently in use. Can you have a comment on this hapten feature? And that might be,
So the question is whether...
No, because for new drug development, very often it is screened of it has hapten capacity or not. Mm-hmm. And clearly paracetamol would be such an example that would not be allowed anymore.
I would say this is probably not predictive. Yeah.
No, I mean, when you screen with paracetamol, I've seen, I work together with some group of Liverpool, and you have a lot of haptenization intracellular, but outside of the liver, not. And there are tolerance mechanisms to tolerate what happens in the liver, also have different haptens. But if it goes outside, then you may have a problem, like for example, sulfamethoxazole NO is actually outside of the body, liver, and then you make an immune reaction, but not inside the liver.
You see, with paracetamol, this toxic metabolite napkin is produced always. When you take 1 gram, you produce it, and of course this gives additions to the proteins, and you have them. We know that, and this has we have quite a lot of literature about that, but nothing happens. So it may be that Werner is right. in one of the rare instances that is right. Okay.
So